Okay, let's get right to it. You know that moment when you're trying to understand something really important, like maybe pregnancy or women's health, and suddenly you're just lost.
Hmm.
It's like a sea of medical terms, complex processes,
Right.
and you just want the core knowledge, you know, explained in a way that actually clicks so you feel informed, confident, without needing, like, a medical degree to decipher it all?
Yeah, that feeling of just wanting clarity, wanting to get it, that's exactly why we do the deep dive. Our mission is pretty straightforward. You bring us your sources, and we pull out the essentials, the insights, the surprising bits maybe, the stuff that really matters for you.
Exactly.
It's all about getting informed efficiently and hopefully avoiding that feeling of information overload.
And today, our learner is looking to really get a handle on the fundamentals of obstetrics and gynecology. The goal, really, is to gain that knowledge quickly, but also thoroughly.
Mm.
We're aiming for those aha moments, right?
Definitely.
And feeling overwhelmed by complicated jargon is, well, the last thing anyone wants.
Precisely. And the source we're using today is this comprehensive medical study guide. It's absolutely packed, dense with critical information.
Okay.
So think of this deep dive as your shortcut, sort of to understanding those core OBGYN concepts, but presented in a clear, hopefully engaging way.
Yeah, so our mission today is simple. Give you a solid grasp of the key ideas in obstetrics and gynecology. We're talking information that's not just medically important, but also, frankly, really interesting, maybe even a bit unexpected here and there.
Right.
We want to equip you with practical knowledge, stuff you'll actually remember.
Okay, so let's dive in right after childbirth, looking at the puerperium and lactation. Now, while the serious conditions in this period, hemorrhage, infection, they're vital, but today let's focus a bit more on the fascinating way the mother's body readjusts and starts nourishing the newborn.
Okay, yeah, I like that. So picture this. Baby's born, placenta's delivered, and it's
Yeah.
like the body just flips a switch, right?
Exactly. It's quite dramatic. Those pregnancy hormones, estrogen and progesterone, they were sky high, and now they just plummet.
Man.
At the exact same time, prolactin, which is the hormone driving milk production, starts to surge.
So it's like an immediate pivot.
It really is.
Yeah.
The body goes from nurturing the pregnancy to, okay, now we nourish the newborn. And what's also pretty remarkable is that this rise in prolactin, it does more than just make milk. It also tends to suppress the hormones that control ovulation, LH and FSH.
Ah, okay.
So for many breastfeeding moms, this leads to a temporary break from periods and ovulation. It can act as a kind of natural birth control, though, not foolproof. Definitely not something to rely on 100%.
Right, right. It's like the body's way of saying, okay, let's focus on feeding this baby for a bit. And then there's the letdown reflex. That always sounded a little mysterious to me.
Yeah, the letdown reflex is actually a beautiful example of hormones and senses working together. When the baby suckles, that sensation triggers the release of prolactin, which, as we said, keeps milk production going. But for the milk to actually come out, the key player is oxytocin, often called the love hormone.
Right.
Oxytocin makes these tiny muscles around the milk ducts contract, squeezing the milk out. And interestingly, that same oxytocin also helps the uterus contract back down to its pre-pregnancy size.
Ah, so it's doing double duty.
Exactly.
Yeah.
A really efficient two-for-one deal, biologically speaking.
So that simple act of suckling has these really profound effects. And I remember hearing that the first milk, colostrum, it's different from the milk that comes later. What's the main difference there?
Yeah, what's fascinating here is how critically designed that early milk is. Colostrum, which is produced in the first few days, it's like a concentrated shot of essentials.
Okay.
It's higher in protein, lower in fat compared to mature milk, and absolutely packed with IgA antibodies.
Yeah, IgA. That sounds important.
It's crucial. These antibodies provide passive immunity to the baby, basically coating and protecting their immature gut from bacteria they're encountering for the very first time. Then, mature milk, which comes in a few days later, has more fat and lactose, the fuel for growth and energy, but still has protein, water, and other key nutrients.
So that IgA and colostrum is like the baby's first shield. Now, breastfeeding has tons of benefits, obviously, but are there situations where it's actually not recommended for the health of the mom or the baby?
That's a really important point, ensuring the well-being of both. And yes, there are specific situations where breastfeeding is contraindicated. For instance, in most developed countries, if the mother has HIV, breastfeeding isn't recommended due to transmission risk. Though I should add, guidelines might differ in resource-poor settings where the benefits might be weighed differently.
Okay, that makes sense.
Other contraindications include active, untreated TB in the mother, active chickenpox or herpes lesions on the breasts, if the mother is undergoing chemo or radiation.
Right.
Also, active substance use, certain specific medications, and a rare condition in the infant called galactosemia are reasons to avoid breastfeeding.
Those all seem logical, prioritizing safety. What about some of the more common hurdles new moms might face when they start breastfeeding? Things like pain or discomfort.
Yeah, common issues definitely come up. Mastitis is one that's often when bacteria get into the breast tissue, maybe through a cracked nipple, causes pain, redness, warmth, sometimes fever.
Ouch.
Breast engorgement is another, that really full, firm feeling. Usually happens early on when supply and demand aren't quite matched yet.
Right.
Nipple soreness, often from a poor latch, is very common. Plugged ducts and galactocele, which are basically milk-filled cysts, can also happen.
Are there simple fixes for those?
Often, yes. For mastitis, surprisingly, continuing to feed or pump from that breast helps clear the infection. For engorgement, frequent feeding, warm or cold compresses can really help. Getting help with latch is key for nipple soreness.
That's really helpful practical stuff. Okay, let's shift gears. Let's go back to the very beginning of pregnancy, the basics, how it's diagnosed. There are a few terms that always pop up, like gravidity and parity.
Okay, yeah, let's clear those up. Gravidity, or G, just refers to the total number of times a woman has ever been pregnant. Doesn't matter if it was a live birth, miscarriage, whatever, just the total number of pregnancies.
Got it. Total pregnancies.
Parity, or P, is a bit more specific. It refers to the number of pregnancies that resulted in a birth after 20 weeks gestation, or, alternatively, the delivery of a baby weighing over 500 grams.
Okay, so outcome focused.
Exactly. And you might see TPL used, too. That gives even more detail. Term deliveries, preterm deliveries, abortions, spontaneous or induced, and living children. So, like, a G3P1 woman has been pregnant 3 times, but only 1 delivery met the parity definition.
Right, that makes sense. G is total, P is outcome past 20 weeks. And then there's gestational age versus embryonic age. That always felt a little confusing.
Yeah, the key thing to understand here is that gestational age is the standard we use in medicine. It's calculated from the first day of the woman's last menstrual period, LMP.
Even though conception is later.
Right, even though fertilization usually happens about 2 weeks after that LMP starts in a typical cycle. Embryonic age is the actual time since fertilization. But because the LMP is usually the most reliable date we have, gestational age is the practical measurement we use to track pregnancy.
Okay, that makes practical sense for consistency. And how do doctors actually figure out that gestational age? It's not just counting from the LMP, right? Especially if that's uncertain.
Good point. While the LMP is the starting point, there are other ways, especially if the dates are fuzzy. Fundal height measuring from the pubic bone to the top of the uterus gives a rough idea after about 20 weeks. It roughly matches the weeks in centimeters then.
Oh, yeah.
We can usually pick up fetal heart tones with a Doppler around 10 to 12 weeks.
Right.
Quickening when the mom first feels the baby move, that's usually around 16 weeks for moms who've had babies before, maybe 20 weeks for first-timers. Okay. But honestly, the most accurate method, especially in the first trimester, say 6 to 12 weeks, is ultrasound measurement of the crown rump length, or CRL.
Ah, ultrasound again.
Yes. Later on, after 13 weeks, we use other ultrasound measurements, head size, BPD, femur length, FL, abdominal circumference, AC. Those become more reliable for dating then.
So ultrasound is really the key, especially early on for accurate dating. And when does pregnancy actually get officially diagnosed? It all comes down to that HCG hormone, doesn't it?
You got it. Human chorionic gonadotropin, HCG. That's the marker. It's made by the developing placenta, and we can find it in both blood, serum, and urine.
So it's more sensitive, right? Earlier detection.
Exactly. Serum tests can pick it up a bit earlier, sometimes even before a missed period. Now, HCG levels typically peak around 10 weeks, then they drop a bit and level off for the rest of the pregnancy.
And the pattern of rising is important, too.
Very important. In a healthy early pregnancy, those HCG levels should roughly double every 48 hours or so. If they aren't rising like that, or if they start falling, it can be a sign of a problem, like a potential miscarriage or maybe an ectopic pregnancy.
So tracking that rise gives really critical early clues. In what specific situations is measuring the exact blood level, the quantitative beta HCG, most helpful?
Yeah, the quantitative test is really useful in several scenarios. Diagnosing ectopic pregnancy is a big one, and also monitoring how well treatment for an ectopic is working.
Okay.
It's also key for diagnosing miscarriage, for monitoring gestational trophoblastic disease, where you might see really high or persistent HCG, and it's one of the markers used in screening tests for fetal aneuploidy, like Down syndrome.
Wow. Okay, quite a range of uses for one hormone level.
Yeah.
And ultrasound is also critical for confirming the pregnancy location, right?
Absolutely critical. Ultrasound confirms it's an intrauterine pregnancy inside the uterus where it belongs. The very first sign we usually see is the gestational sac. On a transvaginal ultrasound, you can typically spot that around 5 weeks gestational age.
So the HCG level would be around.
Usually somewhere between 1,500 and 3,500 MIUML by then. That's sort of the discriminatory zone. Later in pregnancy, we switch to transabdominal ultrasound probe on the belly for the detailed anatomy scans and growth checks in the second and third trimesters.
Okay, so HCG says likely pregnant, ultrasound confirms pregnant and in the right place. Now, once it's established, the woman's body undergoes this incredible transformation. It's way more than just a growing belly, isn't it?
Oh, absolutely. Here's where it gets really fascinating. The physiological changes during pregnancy are just remarkable. They're all orchestrated to support the baby, optimize nutrient and oxygen exchange, and prep the mother's body for labor, delivery, and postpartum. It affects nearly every single system.
Wow. Okay, where do we even start? Cardiovascular system, maybe? I know the heart works harder.
It definitely does. What's interesting is how it adapts. The amount of blood the heart pumps per beat, the stroke volume, increases quite a bit, then plateaus around 19 weeks.
Okay.
The heart rate also gradually creeps up, usually by about 20% over the pregnancy.
So more blood per beat and more beats per minute.
Exactly. Which means the total cardiac output, the amount of blood pumped per minute, goes up significantly, especially in the first half of pregnancy. But here's the twist. While the heart's working harder, the blood vessels actually relax. The peripheral vascular resistance decreases.
Okay. Why is that?
Partly due to hormones like progesterone relaxing smooth muscle. This drop in resistance is why, even though the heart's pumping more blood, blood pressure tends to actually decrease a bit during pregnancy, hitting its lowest point around 34 weeks before coming back up near term.
Huh. That's counterintuitive.
It is. And you might also notice more prominent veins, especially in the legs, and many women develop a harmless systolic flow murmur just from the increased blood volume rushing through the heart.
So more blood pumped, but relaxed vessels keep pressure down. Quite a balance. What about the blood itself? The volume and composition?
Huge changes there, too. Total blood volume increases massively by about 50% by the second trimester.
50%. Wow.
But the plasma, the fluid part, increases more than the red blood cells. So the concentration of red cells actually goes down slightly. We call that dilutional anemia of pregnancy.
Okay.
Levels of clotting factors like fibrinogen go up. Platelet counts might drop slightly. Overall, pregnancy is considered a hypercoagulable state.
Meaning more prone to clotting.
Yes. It's thought to be protective, to minimize blood loss at delivery, but it does mean a slightly higher risk of blood clots during pregnancy and postpartum.
Right. Something to be aware of. How about breathing? I always hear about shortness of breath being common.
Very common. Often it's just the growing uterus pushing up on the diaphragm, making it physically harder to take a deep breath. But physiologically, the amount of air moved with each breath, the tidal volume actually increases quite a bit.
Really? So deeper breaths.
Yeah, deeper breaths, but the breathing rate, the number of breaths per minute, usually stays about the same. The total lung capacity doesn't change much either. But there's less reserve volume, less extra air you can force out. And interestingly, pregnancy causes a mild state of chronic hyperventilation.
Hyperventilation.
Well, a respiratory alkalosis with kidney compensation. It's thought progesterone makes the brain's respiratory center more sensitive.
Huh. So deeper breaths, same rate, feeling shorter of breath.
Okay.
Okay. What about the kidneys? They must be working overtime too.
Definitely. They have to handle waste from both mom and baby. Renal blood flow increases significantly, 25–50%. And the filtration rate, the GFR, goes up early on and stays high.
So they're filtering more blood.
Yes, which means waste products in the blood like creatinine and BUN actually go down. Serum sodium might dip slightly due to dilution, and all that extra filtering means more frequent urination.
Oh, that's fine.
And sometimes the kidneys get overwhelmed trying to reabsorb glucose, so you might see a little leukosuria, even without gestational diabetes.
Okay, that explains a lot. What about the digestive system? Heartburn, constipation? Those seem almost universal.
Very common, yes. Again, hormones play a big role. Progesterone relaxes smooth muscle everywhere, including the sphincter at the top of the stomach.
Leading to reflux.
Exactly, heartburn. Stomach emptying also slows down, and the whole GI tract motility decreases, which contributes to constipation. Progesterone also slows down gallbladder emptying, increasing the risk for gallstones, and the growing uterus can compress veins, leading to hemorrhoids.
It sounds like progesterone is responsible for a lot of the less pleasant side effects. What about other physical changes? Back pain, skin changes.
Low back pain is super common, especially later on. It's the weight of the uterus plus hormones loosening ligaments in the pelvis.
Right.
Skin changes are classic signs too. Chloasma or melasma, those brownish patches on the face, the linea nigra, that dark line down the belly, and the nipples and areolae usually get darker.
Yep, seen those. And finally, the endocrine system beyond HCG. What else is going on hormonally?
The endocrine system is really conducting the whole symphony. Estrogen, progesterone, prolactin, they all progressively increase throughout pregnancy. Beta HCG, as we said, peaks early, then drops.
Okay.
Thyroid hormones are interesting. Total T3 and T4 levels go up. But TSH, the stimulating hormone, often dips slightly in the first trimester, partly because HCG looks a bit like TSH to the body.
So the thyroid is more active?
Not necessarily the free active hormone. Estrogen increases thyroid-binding globulin, TBG, so more hormone gets bound up, raising the total level in the blood. But the free T3 and T4, the ones that actually do the work, usually stay pretty stable in a healthy pregnancy.
Ah, okay, that's a subtle but important distinction. Wow, what an incredible set of adaptations. Okay, let's move into prenatal care and all the diagnostic tests. What's the overarching goal of all these checkups and tests?
Really, the main goal is to identify and manage anything that could negatively impact the health of the mom or the baby. It's about prevention, early diagnosis, and treatment to get the best possible outcome for both.
Makes sense. And I know weight gain recommendations vary, right? It's not the same for everyone.
That's right. It's based on the woman's pre-pregnancy body mass index, or BMI. Someone underweight is advised to gain more than someone who is overweight or obese before pregnancy.
Why is that so important?
Gaining too little is linked to the baby potentially not growing well enough. Gaining too much increases risks for the mom, like gestational diabetes, high blood pressure, and needing a C-section. So it's about finding that healthy balance.
Got it, a tailored approach.
Right.
What about nutrition specifically? Are there key nutrients and things to avoid?
Definitely. Calorie needs go up, maybe 300, 400, or 50 extra calories a day later on, even more if breastfeeding. Folic acid is absolutely critical, 400 micrograms daily before conception, and early on helps prevent neural tube defects like spina bifida.
And sometimes higher doses are needed.
Yes, if there's a history of a neural tube defect or if the woman is on certain medications, the recommendation is much higher, 4,000 micrograms. Iron is vital to prevent anemia. Calcium for baby's bones. Vitamin D and B12 are important to watch, especially for those on vegetarian or vegan diets.
And foods to avoid.
Yes. High mercury fish like shark or swordfish should be avoided. Limit caffeine. Avoid raw or undercooked meat, fish, eggs, and unpasteurized dairy because of the risk of infections like listeria or toxoplasma.
Good reminders. What about exercise? Is it generally safe?
For most healthy pregnancies, yes. Moderate exercise, about 30 minutes most days, is encouraged. It has benefits for both mom and baby. The main thing is to avoid activities with a high risk of falls or abdominal trauma, so no contact sports.
Okay, stay active, but be smart about it. Now, the prenatal visit schedule seems pretty standard. How often does a pregnant woman usually go?
Typically, it's about once a month for the first 28 weeks. Then it increases to every 2 weeks from 28 to 36 weeks. And then it's usually weekly from 36 weeks until delivery. But of course, that can change based on individual risks or complications.
And that very first visit involves a bunch of standard tests, right?
Yep, a baseline workup, usually a complete blood count, CBC, to check for anemia. Blood type and Rh factor are crucial. A urinalysis and urine culture to screen for UTIs. We check immunity to rubella, German measles, and screen for hepatitis B and C, HIV, and syphilis.
That's a thorough start. Now, genetic screening. There seem to be a lot of options these days. Can you walk us through the main ones?
Yeah, it can feel like a lot. In the first trimester, options often include blood tests measuring specific proteins like PPPA and beta HCG, combined with an ultrasound measurement of the nuchal translucency, that's the fluid at the back of the baby's neck. This is usually done between 10 and 13 weeks.
Okay, first trimester combo. Then there's the quad screen later on.
Right, the quadruple screen, usually done between 15 and 20 weeks. It measures 4 things in the mom's blood: MSAFP, inhibin A, estriol, and beta-HCG.
And patterns in those levels can suggest risks.
Exactly. High MSAFP might suggest neural tube defects or abdominal wall defects. Low MSAFP, low estriol, high beta-HCG, and high inhibin A. That pattern is associated with an increased risk for trisomy 21 or Down syndrome. There's a mnemonic, sometimes used for trisomy 21. 2 up, 2 down. Inhibin A and beta-HCG are up. MSAFP and estriol are down.
Oh, that's helpful. 2 up, 2 down.
But remember, these are screening tests. They indicate risk. They don't diagnose. Dating errors can also affect these levels.
Right, screening, not diagnostic. What about cell-free fetal DNA testing? That seems newer.
It is, and it's become quite common. Cell-free fetal DNA, or cfDNA, can be done from 10 weeks on. It analyzes tiny fragments of fetal DNA circulating in the mother's blood.
And it's not invasive.
Yes, just a blood draw from the mom. It's very good at screening for common chromosomal issues like trisomies 21, 18, and 13, and can also tell fetal sex. But again, it's still a screening test, though a highly accurate one.
So for definitive diagnosis, you need the invasive tests, CVS or amniocentesis.
Correct. Chorionic villus sampling, CVS, takes a tiny piece of the placenta, usually between 10 and 13 weeks. Amniocentesis takes a sample of the amniotic fluid, usually between 15 and 20 weeks. Both give definitive genetic information.
But they carry a small risk.
Yes, a small risk of miscarriage. Slightly higher for CVS, around 1%, maybe a bit less for amnio, depending on the center. It's a discussion to have about risks and benefits.
Okay. Then there's that big ultrasound around the middle of pregnancy. The anatomy scan.
Right, the detailed anatomic ultrasound, usually done between 18 and 20 weeks. The main goal is to carefully check all the baby's major organs and structures for any physical abnormalities.
And then later, screening for gestational diabetes.
Yep, usually between 24 and 28 weeks. Starts with a 1-hour glucose challenge test. If that's elevated, then a longer 3-hour glucose tolerance test is done to diagnose gestational diabetes.
And for Rh-negative moms, there's the RhoGAM shot.
Right. Rh immune globulin, usually given around 28 to 30 weeks to prevent the mom from developing antibodies against Rh-positive blood. It's also given after any potential mixing of blood, like after miscarriage, amnio, or significant trauma, and then again after birth if the baby is Rh-positive.
And finally, near the end, the Group B strep culture. Why is that one done?
Group B streptococcus, or GBS. It's a common bacteria that's usually harmless to adults but can cause serious infections in newborns if they're exposed during delivery.
So the test is to see if the mom carries it.
Exactly. A vaginal and rectal swab is done, usually between 35 and 37 weeks. If she's positive or has certain risk factors during labor, she gets IV antibiotics during labor to protect the baby.
Okay, that covers a lot of the routine care. Now let's talk about teratology, how exposures during pregnancy can cause birth defects. It's a sensitive topic.
It is, but important. Major birth defects occur in about 3% of babies at birth, maybe closer to 4.5% by age 5 as some things become apparent later. Teratogens are agents, medications, chemicals, infections, radiation that can disrupt development.
Can you give some examples, specific links between an agent and a defect?
Sure. ACE inhibitors for blood pressure are linked to fetal kidney problems, oligohydramnios, low fluid, and skull defects.
Okay.
Alcohol is a big one. Significant exposure can cause fetal alcohol syndrome growth issues, distinct facial features, brain damage. The risk is definitely dose-dependent.
Right.
Lithium, used for bipolar disorder, is associated with a heart defect called Ebstein's anomaly. Warfarin, the blood thinner, can cause nasal hypoplasia, underdeveloped nose and bone issues, especially with first trimester exposure.
Wow, very specific links. What about radiation from x-rays?
Generally, the dose from diagnostic radiation, like a standard X-ray, is well below the threshold known to cause harm, which is usually considered around 50 milligrays. So the risk is very low.
That's reassuring. What about congenital infections? Infections the baby can get during pregnancy or birth?
Yes, these can unfortunately cause significant problems, things like premature delivery, central nervous system issues, anemia, jaundice, enlarged liver and spleen, growth restriction.
The TORCI acronym is often used here, right?
It is. It helps remember some key ones. Toxoplasmosis, other like syphilis, varicella chickenpox, parvovirus, rubella, cytomegalovirus, CMV, and herpes simplex virus, HSV.
Can we touch on a few of those, like toxoplasmosis?
Sure. Toxo is often from undercooked meat or cat feces. Mom might be asymptomatic, but it can cause chorioretinitis, eye inflammation, hydrocephalus, fluid on the brain, and brain calcifications in the baby. Prevention involves cooking meat thoroughly and avoiding cat litter during pregnancy.
Okay.
Transmitted across the placenta or during birth, can cause rash, swollen glands, liver issues, characteristic snuffles, bone inflammation. Later signs can include distinctive teeth, Hutchinson teeth, saddle nose, deafness. Treatment is penicillin. Screening is key. The big risk is congenital rubella syndrome if infected early in pregnancy. Classic triad is cataracts, deafness, and heart defects. Prevention is vaccination before pregnancy. The vaccine is live and contraindicated during pregnancy.
CMV.
Cytomegalovirus, very common virus, often asymptomatic in mom, can be transmitted transplacentally, can cause a petechial rash, small red spots, and characteristic periventricular calcifications in the brain. Hand washing helps prevent spread.
And HSV, herpes.
Usually transmitted during birth if mom has active genital lesions, can cause skin, eye, mouth infections in the baby, but also potentially life-threatening brain or systemic infection. Antiviral medication like acyclovir is often given near the end of pregnancy to suppress outbreaks, and a C-section is done if lesions are present at delivery.
HIV is also a major concern.
Yes. Transmission can happen in utero, during delivery, or via breastfeeding. With current treatments, antiretroviral therapy for the mother during pregnancy and labor, sometimes elective C-section if viral load is high, and medication for the infant, the risk of transmission is dramatically reduced, often to less than 1%. Breastfeeding is generally avoided in resource-rich settings.
Those are all serious risks. It really highlights the importance of prevention and screening.
Okay, let's shift now to spontaneous abortion or miscarriage. It's incredibly common and often devastating.
It is very common, defined as pregnancy loss before 20 weeks, and the vast majority, over 80%, happen in the first trimester.
What causes them?
Many potential factors. On the maternal side, increasing age, trauma, infections, uncontrolled medical conditions like diabetes or thyroid disease, uterine abnormalities, and environmental factors like smoking, heavy alcohol or caffeine use, certain drugs.
And fetal factors. Fetal factors are huge, especially early on. Chromosomal abnormalities in the fetus account for about 50% of all first trimester miscarriages. Structural malformations can also be a cause. Sometimes underlying genetic issues in the parents can increase risk.
What about recurrent miscarriage? When does it become a pattern needing investigation?
Generally, recurrent spontaneous abortion is defined as 2 or more consecutive losses, or sometimes 3 total losses within a year. When that happens, a workup is usually recommended.
What does that involve?
Often includes karyotyping, chromosome analysis of both parents, testing the mother for thrombophilias, clotting disorders, autoimmune conditions, and anatomical issues with the uterus using imaging.
There are different clinical types of miscarriage, aren't there? The terms can be confusing.
Yes, the terms describe the clinical situation. A threatened abortion means there's bleeding, but the cervix is closed and ultrasound shows a viable pregnancy. It might proceed or it might resolve.
Okay.
An inevitable abortion means bleeding, cramping, and the cervix is open, but the tissue hasn't passed yet. Loss is unavoidable. An incomplete abortion means some tissue has passed, but some remains inside, and the cervix is open.
Okay.
A complete abortion means all the pregnancy tissue has been expelled, the bleeding often subsides, and the cervix closes. Ultrasound shows an empty uterus.
Makes sense.
A missed abortion is when the fetus is no longer viable, but the tissue hasn't passed and the cervix is closed, often discovered on routine ultrasound. An aseptic abortion is any type complicated by uterine infection, fever, pain, foul discharge. This is a medical emergency, and stillbirth is the term for loss after 20 weeks.
That clarifies things. How is a non-viable pregnancy definitively diagnosed early on?
Primarily with transvaginal ultrasound. Specific criteria are used, like seeing a gestational sac over a certain size, usually 25 millimeter without a fetal pole, or seeing a fetal pole over a certain size, usually 7 millimeter without a heartbeat. Ultrasound is really the best initial test. Serial beta HCG levels can be supportive but aren't diagnostic on their own.
And treatment depends on the type.
Yes. For early losses, threatened excluded, options are often expectant management, waiting, medical management with misoprostol to help expel tissue, or surgical management, D&C or MVA manual vacuum aspiration. For later losses, D&E, dilation and evacuation, or induction might be needed. Rh globulin is crucial for Rh-negative mothers, and septic abortion requires immediate antibiotics and surgical evacuation.
Okay, a difficult topic, but important. Let's move to something many experience in early pregnancy. Nausea and vomiting. Morning sickness is the common term, but it can be any time, right? How is it different from hyperemesis gravidarum?
Right. NVP nausea and vomiting of pregnancy is super common. Maybe up to 80% of women have some. Hyperemesis gravidarum is the extreme end of that spectrum.
How extreme?
The key difference is severity and impact. Hyperemesis involves persistent, severe vomiting leading to significant weight loss, like 5% of body weight, dehydration, electrolyte problems, maybe ketosis. It often lasts longer than typical NVP and usually needs medical help. It's also important to rule out other causes for severe vomiting.
So it's really debilitating. How is hyperemesis diagnosed and treated?
Diagnosis is mostly clinical based on the severe symptoms and signs like weight loss, dehydration. Initial tests check electrolytes, ketones. Ultrasound is important to rule out things like molar pregnancy or twins, which can cause worse NVP.
And treatment.
Starts with dietary changes, small, frequent meals, avoiding triggers. First-line meds are often vitamin B6 and doxylamine. If that's not enough, other antiemetics like metoclopramide or ondansetron might be used. 5 fluids are key for dehydration. Sometimes hospitalization for fluids and nutrition is needed.
Sounds rough. Okay, let's talk about another common complication. Diabetes in pregnancy. There's pregestational and gestational, right? What's the basic difference?
Pregestational means the woman had type 1 or type 2 diabetes before getting pregnant. Gestational diabetes, GDM, is diabetes that develops during pregnancy, usually diagnosed in the second or third trimester and typically resolves after delivery.
Are there risk factors that might lead to earlier screening for GDM than the usual 24-28 weeks?
Yes. Things like significant obesity, a strong family history of diabetes, having had GDM before, having delivered a large baby previously, having PCOS, or having certain signs of insulin resistance might prompt screening earlier in pregnancy.
For women with pregestational diabetes, what are the main concerns during pregnancy?
Tight blood sugar control before and during pregnancy is absolutely critical. Poor control, especially early on when organs are forming, significantly increases the risk of birth defects.
Right.
Insulin needs often increase dramatically during pregnancy, sometimes up to threefold. So it requires very close monitoring, frequent insulin adjustments, often working with specialists like endocrinologists. There's also a higher risk of complications like pre-eclampsia, preterm birth, and issues for the baby.
What kind of complications can the baby face if pregestational diabetes isn't well controlled?
A range of things. Increased risk of congenital malformations, heart, brain, spine defects are common ones. Macrosomia being born very large, which can cause delivery problems like shoulder dystocia. Sometimes growth restriction can happen too. After birth, babies are at risk for hypoglycemia, low blood sugar, hypocalcemia, low calcium, hyperbilirubinemia, jaundice, and respiratory distress syndrome. Stillbirth risk is also higher with poor control.
Really highlights the need for preconception counseling and tight control. Now, for gestational diabetes, how does it usually present and how is it diagnosed?
Often GDM is asymptomatic. The mom might not notice anything different, sometimes increased thirst or urination, but usually it's picked up by screening.
The glucose test.
Right. The standard approach is usually a two-step process. First, a 1-hour, 50-gram glucose challenge test between 24-28 weeks. If that's above a certain threshold, often 140 mg/dL, but can vary, then a 3-hour, 100-gram glucose tolerance test is done. 2 or more abnormal values on the 3-hour test confirms the GDM diagnosis.
But how is GDM managed? Is it always insulin?
Not always. The first step is usually lifestyle dietary changes, often seeing a nutritionist, and moderate exercise. Home blood glucose monitoring, usually 4 times a day, is key.
All right.
If diet and exercise aren't enough to keep sugars in the target range, like fasting 95, 1 hour post-meal 140, 2-hour 120, then medication is needed. Insulin is considered the gold standard because it doesn't cross the placenta much. Oral meds like metformin or glyburide are sometimes used, but insulin is generally preferred.
What are the main complications of GDM for mom and baby?
For the mom, having GDM increases her risk of GDM in future pregnancies and significantly increases her lifetime risk of developing type 2 diabetes later. She needs postpartum screening.
Right.
For the baby, the biggest risk is macrosomia being large for gestational age. This increases the risk of shoulder dystocia during delivery and the need for a C-section. Neonatal hypoglycemia is also a risk. Unlike pregestational diabetes, GDM diagnosed later usually doesn't cause birth defects because the organs are already formed.
Okay, that's an important distinction. Let's shift to hypertensive disorders in pregnancy. Different categories here too, right?
Yes, high blood pressure issues are a major concern. Chronic hypertension is high BP present before pregnancy or diagnosed before 20 weeks gestation. Gestational hypertension is new high BP, O140 systolic or A90 diastolic, after 20 weeks, but without significant proteinuria or other signs of organ damage. It usually resolves postpartum.
And pre-eclampsia.
Pre-eclampsia is a more serious one. It's new onset hypertension after 20 weeks. PLUS, either proteinuria, significant protein in the urine, or are, even without proteinuria, signs of end organ damage like low platelets, high liver enzymes, kidney problems, pulmonary edema, or new visual or brain disturbances.
Can women with chronic hypertension get preeclampsia too?
Yes, that's called superimposed preeclampsia, and they are at higher risk for it. About a third of women with chronic hypertension might develop it. Women with gestational hypertension also have about a 25% risk of progressing to preeclampsia.
How are chronic and gestational hypertension managed?
Close BP monitoring is key. For chronic HTN, women often stay on safe antihypertensive meds like methyldopa, labetalol, or nifedipine. For gestational HTN, meds are started if BP gets too high, like all 160 systolic or all 110 diastolic, considered severe. ACE inhibitors and ARBs are definitely avoided due to fetal risks. Diuretics are usually avoided too.
So preeclampsia is the one with high BP and proteinuria or organ issues. What puts someone at higher risk for it?
Several things. Being a first-time mom, nulliparity, carrying multiples, having a molar pregnancy, pre-existing kidney disease or diabetes, a family history of preeclampsia, chronic hypertension, obesity, older maternal age.
How is preeclampsia treated? What's the cure?
Low-dose aspirin daily is often recommended for high-risk women to help prevent it. But once it develops, the only definitive cure is delivery of the baby and placenta.
So management depends on how far along the pregnancy is.
Exactly. If it's close to term, like 37 weeks or later, or if it's severe or worsening at any stage, delivery is usually indicated. If it's preterm and mild, sometimes expectant management with very close monitoring in the hospital is possible.
And magnesium sulfate is used.
Yes, magnesium sulfate is given intravenously to prevent seizures, eclampsia. It's standard for preeclampsia with severe features and for eclampsia itself. Antihypertensives like IV labetalol or hydralazine are used to control severely high blood pressure. Close monitoring of mom, reflexes for magnesium toxicity, urine output labs, and baby is crucial.
And eclampsia is.
Eclampsia is preeclampsia plus the occurrence of seizures. It's a true obstetric emergency, often preceded by warning signs like severe headache, visual changes, or upper abdominal pain. Treatment is immediate seizure control. Magnesium is first line, stabilizing the mother, and prompt delivery.
Okay, let's move to urinary tract infections, UTIs, and pregnancy. More common then.
Yes, definitely more common due to urinary tract changes. We screen for asymptomatic bacteria in urine without symptoms, usually at the first prenatal visit or around 12-16 weeks.
Why screen if there are no symptoms?
Because untreated asymptomatic bacteriuria in pregnancy significantly increases the risk of developing pyelonephritis, a kidney infection later on, which can be serious.
Okay, and symptomatic UTIs.
Cystitis, bladder infection, causes the typical UTI symptoms: dysuria, painful urination, urgency, frequency. Pyelonephritis, kidney infection, adds fever, chills, flank pain, nausea, vomiting.
How are they diagnosed and treated?
Urinalysis and urine culture are key. For asymptomatic bacteriuria and cystitis, a short course, 3 to 7 days, of pregnancy-safe antibiotics like nitrofurantoin, though best avoided in first trimester if possible, cephalexin or amoxicillin clavulanate is used. Fluoroquinolones and Bactrim, TMP-SMX, are generally avoided, especially in the first and third trimesters. A follow-up test of culture is important.
And pyelonephritis.
That usually requires hospitalization, IV fluids, and 5E antibiotics, like third-generation cephalosporins initially. Then switch to oral antibiotics based on culture results. Sometimes suppressive antibiotics are needed for the rest of the pregnancy. And importantly, if a woman has GBS in her urine at any point, she needs GBS prophylaxis during labor.
Got it. There are a few other, maybe less common, but serious complications, like cholestasis of pregnancy.
Right. Intrahepatic cholestasis of pregnancy typically presents in the third trimester with intense itching, especially on the palms and soles, often worse at night, but usually without a rash.
Itching. Why is that serious?
Because it's associated with elevated bile acids in the mother's blood, which can cross the placenta and increase the risk of stillbirth, preterm delivery, and meconium staining. Labs show high bile acids, most sensitive test, and often elevated liver enzymes too. Management involves medication like ursodeoxycholic acid to help itching and lower bile acids, and often induction of labor around 36-37 weeks.
Okay, itching needs investigation. What about acute fatty liver of pregnancy?
That's a rare but life-threatening emergency, usually in the third trimester. It involves rapid liver failure. Symptoms include nausea, vomiting, abdominal pain, jaundice. Labs show very high liver enzymes, low platelets, signs of kidney failure, low blood sugar. The only treatment is immediate delivery. Maternal and fetal mortality can be high if not recognized and treated quickly.
Wow, scary. Okay, let's revisit complications related to location ectopic pregnancy.
Ectopic pregnancy is when the fertilized egg implants outside the uterus, 95% of the time in the fallopian tube. Classic symptoms are unilateral lower abdominal pain and vaginal spotting early in pregnancy.
How is it diagnosed?
Key is a positive pregnancy test, but no intrauterine pregnancy seen on transvaginal ultrasound, especially when the beta-HCG level is above the discriminatory zone, around 1500–3500. Treatment depends on the situation. Methotrexate injection can be used for small, unruptured ectopics in stable patients. Otherwise, surgery, often laparoscopic salpingostomy to save the tube or salpinectomy to remove it, is needed, especially if it's ruptured.
Okay. What about placental abruption versus placenta previa? Both involve the placenta, right?
Yes, but they're very different. Placental abruption is the premature separation of a normally implanted placenta from the uterine wall before delivery.
What causes that?
Risk factors include hypertension, smoking, cocaine use, trauma, prior abruption. It typically presents with painful, dark red vaginal bleeding, a rigid, tender uterus, and often signs of fetal distress. Diagnosis is mainly clinical. Ultrasound might show a clot but isn't very sensitive.
And management.
Depends on severity and gestational age. Mild abruptions might be managed expectantly in the hospital with close monitoring if preterm. Moderate to severe abruptions usually require immediate delivery vaginal if mom and baby are stable, C-section if there's fetal distress or significant bleeding. Importantly, avoid vaginal exams if previa is suspected.
Okay, so abruption is separation. What's placenta previa?
Previa is when the placenta implants low in the uterus, partially or completely covering the cervical opening. Risk factors include prior C-sections, prior previas, multiparity, older age, smoking.
How does that present?
The hallmark is painless, bright red vaginal bleeding, often starting in the second or third trimester. It might stop and start. Fetal distress is less common initially than with abruption. Diagnosis is made by ultrasound transvaginal, is safe and accurate.
And management.
If found early, it might resolve as the uterus grows. If it persists, management involves avoiding vaginal exams, pelvic rest, close monitoring, often hospitalization if bleeding occurs, giving corticosteroids for fetal lung maturity if preterm, and planning for a C-section delivery, usually around 36–37 weeks or sooner if significant bleeding occurs.
So painful bleeding, think abruption. Painless bleeding, think previa. What's vesa previa?
Vesa previa is rare but dangerous. It's when fetal blood vessels run unprotected in the membranes over or very close to the cervix, often associated with a low-lying placenta or velamentous cord insertion.
Why is it dangerous?
Because if the membranes rupture, those fetal vessels can tear, leading to rapid fetal blood loss and bradycardia, slow heart rate. Diagnosis can sometimes be made prenatally with transvaginal ultrasound and color Doppler. If found, a planned C-section before labor starts is essential. If acute bleeding occurs at membrane rupture, it's an emergency C-section.
Okay. Multiple gestations, twins, triplets, any specific risks?
Yes, definitely higher risks. Moms have higher rates of pre-eclampsia, GDM, preterm labor, PPH, C-section. Babies have higher rates of prematurity, low birth weight, FGR, congenital anomalies.
And twin-specific issues.
With identical twins sharing a placenta, monochorionic, there's risk of twin transfusion syndrome, TTTS. If they share an amniotic sac too, monoamniotic, there's risk of cord entanglement.
You mentioned FGR fetal growth restriction. What causes that?
FGR is when the estimated fetal weight is below the 10th percentile for gestational age. It can be symmetric, baby is proportionally small all over, often due to early insults like genetic issues or infection, or asymmetric, head is spared relative to the body, usually due to later problems like placental insufficiency from maternal conditions like hypertension. Complications include stillbirth, preterm birth, hypoxia, hypoglycemia.
What about amniotic fluid levels? Too much or too little?
Polyhydramnios is too much fluid. AFI 24 centimeters or deepest pocket 08 centimeters. Can be caused by maternal diabetes, multiple gestation, fetal anomalies like GI or CNS issues, or isoimmunization. Can lead to preterm labor, malpresentation, cord prolapse. Treatment might involve therapeutic amniocentesis if severely symptomatic. Oligohydramnios is too little fluid, AFI 5 centimeters or deepest pocket 2 centimeters, often related to fetal kidney problems, placental insufficiency, post-term pregnancy, or ruptured membranes. Complications include FGR, fetal distress, pulmonary hypoplasia, underdeveloped lungs, limb contractures.
And Rh-ASO immunization, we talked about prevention with RhoJam. What happens if a mom is already sensitized?
If an Rh-negative mom has already developed antibodies against Rh-positive blood, for example, from a prior pregnancy without RhoJam, she's monitored closely with antibody titers. If titers rise above a critical level, like 1.16, the fetus is monitored very closely for signs of anemia using Doppler ultrasound of the middle cerebral artery. Severe fetal anemia might require preterm delivery or even intrauterine blood transfusions.
Wow. Okay, that covers a lot of complications. How do providers assess fetal well-being during pregnancy, especially in high-risk situations?
There are several tools. One simple one is fetal movement assessment, the mom counting kicks. A significant decrease warrants evaluation.
Okay.
Then there's the non-stress test, NST. We monitor the fetal heart rate for about 20-30 minutes, looking for accelerations. Heart rate speeding up by 15 beats for 15 seconds. 2 or more accelerations is reactive and reassuring. Non-reactive needs further testing,
Like what?
like a biophysical profile, BPP, or sometimes a contraction stress test, CST. The CST involves inducing contractions with oxytocin or nipple stimulation and seeing how the baby's heart rate responds. We look for late decelerations, which can be concerning, but CST isn't done if there's risk of preterm labor or previa.
And the BBP?
The BPT combines the NST with an ultrasound assessment of 4 things: fetal breathing movements, gross body movements, fetal tone, and amniotic fluid volume. Each gets a score of 0 or 2. Total score of 8-10 is reassuring. 6 is equivocal, needs repeat or delivery if term. 0-4 is worrisome, often warrants delivery. A helpful mnemonic is PEST the baby, man. Tone, breathing, movement, amniotic fluid, NST.
Okay, test the baby, man, Ann. I like that. And amniotic fluid index, AFI, is part of that.
Yes. AFI measures the fluid in 4 quadrants. An umbilical artery Doppler velocimetry is sometimes used, especially with FGR, to assess blood flow through the cord. Abnormal flow, decreased, absent, or reverse diastolic flow, is concerning.
Got it. A range of tools to check on the baby. Now let's talk about normal labor and delivery itself. What's the official definition of labor?
Labor is defined by regular uterine contractions that cause progressive cervical change, meaning effacement, thinning, and dilation opening, leading to delivery.
And the obstetric exam during labor involves?
Several things. Leopold maneuvers to feel the baby's position from the outside. Cervical exam to check dilation, 0-10 centimeters. Effacement, 0-100%. Station, how low the baby is relative to the ankle spines, -3 to +3, 0 is engaged. Cervical position and consistency. We also confirm the presenting part, head, breech. Sterile speculum exam if we suspect membranes have ruptured.
Station is how low the baby is.
Right. 0 station means the presenting part is right at the level of the ischial spines in the pelvis. Negative numbers mean above the spines, positive numbers mean below. Engagement usually means 0 station.
Sometimes labor needs a little help. Augmentation.
Yes, if contractions aren't strong or frequent enough to progress labor, augmentation with oxytocin, pitocin might be used. Misoprostol can be used for cervical ripening. Oxytocin does have risks, like uterine tachysystole, too many contractions, potential hypertension, or water intoxication at high doses.
And fetal heart rate monitoring is constant during labor.
Typically, yes. Can be external, Doppler on the belly, or internal, scalpel electrode, needs ruptured membranes. Normal rate is 110-160 BPM. Bradycardia, 110, or tachycardia, 160, can indicate issues like hypoxia, fever, cord compression.
And variability in D cells.
Variability of beat-to-beat fluctuations is really important. Moderate variability is reassuring. Accelerations are good. Decelerations, we use VL-SHUP. Variable D cells, cord compression. Early D cells, head compression. Accelerations, okay. Late D cells, placental insufficiency. Late D cells are the most concerning.
Okay, VL-CHAP, good one. Labor pain. What are the options?
Pain comes from uterine contractions and cervical dilation, visceral pain, T10-L1 nerve roots, and later from pressure on the pelvic floor, somatic pain, S24 pudendal nerve.
So different types of relief.
Options range from non-pharmacologic, breathing, movement, massage, water, to medications. A pudendal block numbs the perineal area for the pushing stage. An epidural block is most common for significant pain relief anesthetic infused into the epidural space. Works for labor and C-sections.
Epidural side effects.
Most common is temporary hypotension from sympathetic blockade. Spinal headache if the dura is accidentally punctured. Urinary retention. Contraindications include severe low blood pressure, clotting disorders, or being on certain blood thinners.
What about preterm labor? Labor starting before 37 weeks.
Right. Regular contractions plus cervical change before 37 weeks. Evaluation involves ruling out ruptured membranes, checking for infection, UTI, GBS, STIs, ultrasound to check baby. If confirmed, we assess if tocolysis, meds to stop contractions, is appropriate. It's contraindicated if there's infections, significant bleeding, or non-reassuring fetal status.
And rupture of membranes, ROM.
Can be spontaneous ROM at or after labor starts. Premature ROM, PROM, is rupture 1 hour before labor starts. If it happens before 37 weeks, it's preterm PROM, PPROM. Prolonged ROM is 18 hours between rupture and delivery, increasing infection risk.
How is ROM diagnosed and managed?
Usually a history of a gush of fluid. A diagnosis confirmed with a sterile speculum exam looking for pooling of fluid in the vagina, testing the fluid pH, nitrazine paper turns blue, looking for a ferning pattern under microscope. Ultrasound might show low fluid. Management depends heavily on gestational age.
How so?
At term, 37 weeks, usually induce labor if it doesn't start soon. Between 34-36 weeks, often induce. Before 34 weeks, if no infection, often expectant management and hospital monitor for infection, give antibiotics to prolong latency period, give corticosteroids, betamethasone, for fetal lung maturity. If signs of infection, chorioamnionitis, or fetal distress occur at any stage, antibiotics and delivery are needed. Minimize digital vaginal exams once membranes are ruptured to reduce infection risk.
Okay. C-sections. What are the main reasons for needing one?
Lots of potential reasons. Maternal. Prior classical C-section, vertical uterine scar, active genital herpes, invasive cervical cancer, maternal health crises, fetal-maternal combined, failure to progress in labor, CPD, placenta previa, placental abruption, failed attempt at operative vaginal delivery, vacuum forceps. Fetal, non-reassuring fetal status, malpresentation, breech transverse, suspected macrosomia, some congenital anomalies. Having had a prior low transverse C-section is a relative indication. VBAC, vaginal birth after C-section, is often an option.
What about infection during labor? Chorioamnionitis.
Intraamniotic infection, or chorioamnionitis, usually bacteria ascending from the vagina after membranes rupture. Risks include PPROM, long labor, internal monitors, multiple exams, causes maternal fever, uterine tenderness, rapid heart rate, sometimes foul discharge, requires broad-spectrum IV antibiotics like ampicillin and gentamicin, and usually augmenting labor to expedite delivery. Can cause complications for mom, PPH, endometritis, and baby, pneumonia, sepsis, encephalopathy.
Malpresentation, baby not being head down.
Right, anything other than vertex. Breech, butt, or feet first is most common. Risks include prematurity, uterine anomalies, multiples, abnormal fluid levels.
How is it managed?
Many breech babies turn on their own before term. External cephalic version, ECV, can be attempted around 37 weeks to manually turn the baby from the outside, about 50% successful, carries small risks like abruption, so needs to be done where C-section is available. Trial of vaginal breech delivery is sometimes possible, but carries higher risks. Cord prolapse, head entrapment, so elective C-section is generally recommended for persistent breech presentation. Transverse lie always requires C-section.
Umbilical cord prolapse sounds like an emergency.
It is. The cord slips down ahead of the baby after membranes rupture. Compresses the cord, cutting off oxygen. Risk factors include ROM when the head isn't engaged, malpresentation, polyhydramnios. Diagnosed by seeing or feeling the cord, often sudden, severe fetal heart rate decelerations. Treatment is immediate. Manually lift the presenting part off the cord. Call for help. Get to OR for emergency C-section. Keep hand in vagina, lifting head until delivery.
Shoulder dystocia.
Another emergency. Head delivers, but the anterior shoulder gets stuck behind the pubic bone. Recognized by the turtle sign, head retracts. Risks: maternal obesity, diabetes, suspected large baby, prior dystocia. Management involves specific maneuvers, like Roberts, hyperflexing mom's legs, suprapubic pressure, delivering the posterior arm, sometimes intentionally fracturing the clavicle. Excessive traction can cause brachial plexus injury to the baby, Erb's palsy.
Episiotomy.
A surgical cut to enlarge the vaginal opening, less common now, median, straight back, or mediolateral angled.
Uterine inversion.
Rare but serious PPH cause. Uterus turns inside out after delivery, often from too much cord traction or fundal pressure. See a red, fleshy mass at the introitus, severe pain, shock, can't feel fundus abdominally, needs immediate manual replacement. Stop uterotonics until replaced.
Okay, that covers labor and delivery emergencies. Now, the postpartum period. What's normal? Lochia.
Lochia is the normal postpartum discharge as the uterine lining sheds. Starts red, rubra, for a few days, then pinkish-brownish serosa, then yellowish-white alba by 2 weeks, can last 3 to 6 weeks.
Urinary retention.
Common initially due to bladder atony swelling, usually resolves spontaneously, may need temporary catheterization. Ambulation helps.
Postpartum hemorrhage, PPH, the big concern. Definition. Causes.
Key pH is 500 milliliter blood loss after vaginal delivery, or 1,000 milliliter after C-section. Early is within 24 hours, late is 24 hours to 6 weeks. Signs are heavy bleeding, dizziness, signs of shock. Number one cause, by far 80%, is uterine atony. Uterus fails to contract, feels soft and boggy.
What increases risk for atony?
Uterine overdistension, multiples, polyhydramnios, large baby, prolonged or rapid labor, infection, retained placenta, fibroids, anesthesia interfering with contraction.
How is atony treated?
First step is vigorous uterine massage, then uterotonic medications, oxytocin infusion, methergine, contraindicated in hypertension, hemabate, PGF2 alpha, contraindicated in asthma.
Other causes of PPH?
Genital tract trauma, lacerations, is next most common, 15%. Need to inspect carefully and repair tears. Retained placental tissue, 5%. If pieces are left behind, uterus can't contract well. Need manual removal, or DNC. Rare causes are uterine inversion or coagulation defects, DIC. The 4T's mnemonic helps. Tone, trauma, tissue, thrombin.
Postpartum infection.
Defined as fever, O38C, 48C5, on 2+ of the first 10 postpartum days, excluding first 24 H's. Big risk factor is C-section, especially emergent. Others? PROM, prolonged labor, multiple exams, internal monitors.
Most common infection.
Endometritis infection of the uterine lining. Presents with fever, uterine tenderness, foul-smelling lochia. Requires broad-spectrum IV antibiotics like clindamycin and gentamicin. Septic pelvic thrombophlebitis is rare infected clot in pelvic veins. Causes persistent high-spiking fevers despite antibiotics. Needs anticoagulation too.
Peripartum cardiomyopathy, Sheehan syndrome.
Peripartum cardiomyopathy is heart failure developing late in pregnancy or early postpartum. Sheehan syndrome is pituitary gland damage from severe PPH shock, leading to pituitary hormone deficiencies. Classic first sign is failure to lactate, low prolactin.
Okay, that covers postpartum. Let's pivot to gynecology, women's health outside of pregnancy, starting with puberty and the menstrual cycle.
Right. Normal female puberty usually follows a sequence. The Larsh breast buds, age 8-13, pubarch, pubic hair, growth spurt menarche, first period, age 10-16. There's variation, of course.
And the normal menstrual cycle, the hormonal dance.
It's complex. Average cycle is 28 days. Follicular phase, first 14 days. Starts with menses. Hypothalamus releases GnRH, pituitary releases. FSH stimulates ovarian follicles to grow. Follicles make estrogen. Estrogen builds up uterine lining, proliferative endometrium. One follicle becomes dominant.
Then ovulation.
Right around day 14, high estrogen triggers an LH surge from the pituitary. LH causes the dominant follicle to rupture, releasing the egg, ovulation. The ruptured follicle becomes the corpus luteum.
And the second half.
That's the luteal phase, days 15-28. Corpus luteum makes progesterone and some estrogen. Progesterone prepares the uterine lining for implantation, secretory endometrium. If no pregnancy occurs, corpus luteum dies after 10-14 days. Progesterone estrogen levels fall, triggers shedding of the lining, menses. FSH starts to rise again, beginning a new cycle.
What about precocious puberty? Starting too early.
Puberty signs before age 8 in girls can be central, GnRH dependent. The whole brain pituitary ovary axis activates early. Might be idiopathic or due to CNS issue. Or peripheral GnRH independent sex hormones coming from somewhere else, like a ovarian cystomer or adrenal issue like CAH or external exposure.
How is it diagnosed and treated?
Evaluation includes checking bone age, usually advanced, hormone levels. A GnRH stimulation test helps differentiate central versus peripheral. Central shows LH surge. Imaging, brain MRI, pelvic US looks for causes. Treatment targets the cause. GnRH agonists can suppress central puberty, surgery for tumors, meds for CAH.
What about the opposite delayed puberty or primary amenorrhea?
Primary amenorrhea is no period by 15 with normal growth, secondary sex characteristics. Or R, no period and no secondary sex characteristics by 13. That's delayed puberty.
Cause.
If no secondary sex characteristics, often primary ovarian insufficiency, like Turner syndrome, gonadal dysgenesis, chemoradiation damage, or central issues, hypothalamic pituitary. If secondary characteristics are present but no period, could be an outflow tract obstruction, imperforate hymen, malarianogenesis, absent uterus, or maybe androgen insensitivity syndrome.
How's it evaluated?
First, pregnancy test. Rare, but possible. Physical exam for anatomy. Pelvic ultrasound is key. If uterus is absent, check karyotype and testosterone, differentiates malarianogenesis from androgen insensitivity. If uterus is present, check FSH-LH. High FSH suggests ovarian failure, hypergonadotropic hypogonadism. Low normal FSH suggests central problem, hypergonadotropic hypogonadism.
Okay. Secondary amenorrhea is periods stopping after they've started.
Right, no period for 6 months or 3 typical cycles in someone who previously menstruated.
Causes here.
Most common, pregnancy. Always rule that out first. Then, ovary issues, PCOS, premature ovarian insufficiency, hypothalamic problems, functional amenorrhea from stress, weight loss, exercise, tumors, pituitary issues, prolactinoma, Sheehan's, thyroid dysfunction, hypo or hyper, uterine problems, Asherman syndrome, scarring,
Evaluation.
history, exam, pregnancy test, then typically check TSH, prolactin, FSH, high FSH ovarian insufficiency, high TSH hypothyroidism, hyperlactin, check pituitary MRI. If those are normal, maybe progestin challenge tests, see if withdrawal bleed occurs, follow algorithms based on results, treatment targets the underlying cause.
Dysmenorrhea, painful periods. Primary versus secondary.
Primary dysmenorrhea is pain without underlying pelvic pathology. Starts with ovulatory cycles, caused by excess prostaglandins, PGF2-alpha, causing uterine contractions ischemia. Typical crampy midline lower pelvic pain, maybe radiating to back thighs, sometimes nausea, diarrhea, starts just before or with menses. Secondary dysmenorrhea is pain due to an underlying condition like endometriosis, adenomyosis, fibroids, PID, adhesions. Pain might be different, start earlier, last longer, may be associated with other symptoms.
Diagnosis and treatment.
Primary is diagnosis of exclusion. Treat with NSAIDs, block prostaglandins, heat, hormonal contraception, OCPs, progestin IUD. Secondary requires finding the cause exam, ultrasound, maybe MRI or laparoscopy. Treatment targets the specific pathology.
Abnormal uterine bleeding, AUB. Common complaint. How is it classified?
Defined as changes in frequency, duration, regularity, or amount of bleeding. We use the PALM-COEIN system.
Cool.
PALM, structural causes, polyps, adenomyosis, leiomyoma, fibroids, malignancy, hyperplasia, COEIN, non-structural, coagulopathy, ovulatory dysfunction, endometrial causes, iatrogenic, meds, SUDs, not yet classified.
Specific terms.
Oligomenorrhea, infrequent, 35-90 days apart. Polymenorrhea, too frequent, 21 days. Heavy menstrual bleeding, HMB 80 ml or 8 days. Intermenstrual bleeding between periods.
Evaluation.
History, pattern, amount, pelvic exam, check uterus size, shape, cervix. Pregnancy test, CBC, check for anemia, pap smear. Maybe gonorrhea chlamydia testing. TSH, prolactin, coagulation studies if suspected bleeding disorder, like von Willebrand's. Pelvic ultrasound is key. Fibroids, polyps, endometrial thickness.
Endometrial biopsy needed sometimes.
Yes, crucial in certain situations. Postmenopausal women with any bleeding or thickened stripe, 4 millimeters on US. Premenopausal women 35 with risk factors for endometrial cancer, obesity, chronic anovulation like PCOS, diabetes, tamoxifen use, and AUB,
Right.
or persistent AUB despite treatment.
Treatment for AUB.
Depends entirely on the cause and patient goals. Acute severe bleeding might need high-dose IV estrogen or DNC. Chronic HMB often responds well to hormonal contraception, OCPs, progestin IUD. Anovulatory bleeding usually managed with cyclic progestins or OCPs. Surgical options, polypectomy, myomectomy, ablation, hysterectomy for structural issues or failed medical management. Untreated AUB can lead to anemia and, with chronic anovulation, risk of endometrial hyperplasia cancer.
Contraception, lots of methods. Can you give a quick overview?
Sure. Combined hormonal, estrogen plus progestin pills, patch, ring work by stopping ovulation, thickening mucus, very effective. Progestin-only mini pills, injection Depo-Provera, implant, Nexplant, hormonal IUDs, Mirena, Kylena, etc. Good if estrogen contraindicated. Also, thicken mucus, may stop ovulation. IUDs, hormonal or copper, long-acting, reversible, highly effective. Copper IUD is non-hormonal. Barrier condoms, male-female, diaphragm, cervical cap sponge, prevent sperm meeting egg. Condoms also prevent STIs. Effectiveness varies with correct use. Fertility awareness-based methods tracking cycle signs to avoid intercourse during fertile window requires diligence. Sterilization, tubal ligation, women, vasectomy, men, permanent. Withdrawal is not reliable.
Contraindications to combined methods.
Absolute ones include history of VTE, clots, stroke, certain heart disease, uncontrolled hypertension, smoking at 35, migraine with aura, estrogen-dependent cancer like breast cancer, active liver disease, pregnancy, unexplained vaginal bleeding.
NIUDs.
Pregnancy, current pelvic infection, PID, unexplained bleeding, suspected gyn cancer, distorted uterine cavity.
Okay. Hyperandrogenism, excess male hormones in women.
Right. Leads to hirsutism, male pattern hair growth, acne, sometimes irregular periods. More severe form is virilization includes clitoromegaly, voice deepening, male pattern balding. Suggests very high androgen levels, maybe from a tumor.
Causes.
Most common is PCOS, polycystic ovary syndrome. Also, congenital adrenal hyperplasia, CAH, genetic enzyme defects in cortisol pathway lead to androgen buildup. 21-hydroxylase deficiency is most common form. Classic salt wasting or non-classic late onset. Less common are androgen-secreting tumors, ovary or adrenal.
Diagnosing CAH.
Measuring specific hormone precursors. High 17-hydroxyprogesterone suggests 21-hydroxylase deficiency. High 11-deoxycortisol suggests 11-beta-hydroxylase deficiency, often causes hypertension too.
And PCOS, how's that diagnosed?
Usually based on the Rotterdam criteria, need 2 out of 3. 1. Clinical or biochemical signs of hyperandrogenism, hirsutism, acne, high testosterone.
Yeah.
2. Oligo or anovulation, irregular periods. 3. Polycystic ovaries on ultrasound, string of pearls appearance. Need to rule out other causes like CAH, tumors, thyroid issues, often associated with insulin resistance, obesity, metabolic syndrome.
Treating PCOS.
Lifestyle, weight loss if overweight, is key for fertility. Letrozole is often first line now, sometimes metformin. For symptoms, OCPs help regulate cycles and reduce hirsutism acne. Antiandrogens like spironolactone for hirsutism. Metformin for insulin resistance metabolic issues. OCPs also protect the endometrium from unopposed estrogen. Complications include infertility, miscarriage, type 2 diabetes, metabolic syndrome, long-term increased risk of endometrial cancer.
Infertility, difficulty conceiving.
Defined as unable to conceive after 1 year of unprotected intercourse, 35-yo, or 6 months, or 35-yo. Can be primary, never conceived, or secondary. Causes can be female factor, 40-50%, male factor, 30-40%, combined, or unexplained.
Female factors. Workup.
Common female factors. Ovulatory dysfunction, PCOS is a big one. Tubal blockage from PID, endometriosis. Uterine issues, fibroids, polyps, scarring. Diminished ovarian reserve, cervical factors. Workup starts with history, physical. Then check ovulation, progesterone level mid-luteal phase, tracking. Assess ovarian reserve, early follicular FSH, AMH, antral follicle count on US. Check TSH, prolactin. Evaluate tubes uterus, often hysterosalpingogram, HSG. Dye test. Maybe laparoscopy if endometriosis adhesion suspected. Male partner needs semen analysis early on.
Treatment.
Depends on cause. Ovulation induction meds. Clomiphene, letrozole, gonadotropins. Surgery for tubal-uterine issues. Intrauterine insemination, IUI. In vitro fertilization, IVF. Treat underlying conditions like thyroid disease or hyperprolactinemia.
Menopause, end of periods.
Yes, cessation of menses for 12 consecutive months due to ovarian follicular depletion. Average age 51. Before 40 is premature ovarian insufficiency. Symptoms. Vasomotor symptoms, hot flashes, night sweats are classic. Vaginal dryness atrophy, genitourinary syndrome of menopause GSM, sleep disturbance, mood changes, irritability, anxiety, trouble concentrating, joint aches, changes in libido, long-term risk of osteoporosis.
Diagnosis and treatment.
Usually clinical diagnosis based on age and symptoms. FSH levels will be high, but not always needed for diagnosis. Treatment focuses on symptom relief. Hormone therapy, estrogen plus progestin if uterus intact, is most effective for vasomotor symptoms and GSM. Risks benefits depend on age, time since menopause, individual factors. Generally considered safe for symptomatic women 60 or within 10 years of menopause. Contraindications include history of breast cancer, VTE, liver disease. Non-hormonal options for hot flashes include SSRIs, NRIs, gabapentin. Vaginal estrogen is very effective and safe for GSM. Lifestyle helps. Osteoporosis screening recommended, usually starting at 65.
Okay, let's cover some common benign GYN disorders. Bartholin cyst abscesses.
Bartholin glands lubricate the vaginal opening. If the duct blocks, a cyst forms, often painless. If it gets infected, it becomes a painful abscess. Treatment for abscess is incision and drainage. Recurrent ones might need a word catheter placed or marsupialization, creating a permanent opening. Antibiotics only if surrounding cellulitis.
Vaginitis, common causes.
Inflammation, infection, causing discharge, itching, irritation. Top 3, bacterial vaginosis, BV, imbalance of normal flora, fishy odor, thin gray discharge, pH 4.5. Candidiasis, yeast, itching, thick white cottage cheese discharge, normal pH. Trichomoniasis, STI parasite, itching, frothy yellow-green discharge, strawberry cervix, pH 4.5. Diagnosis via symptoms, exam, wet mount microscopy, pH, whiff test. Treatment, metronidazole Eclinda for BV, antifungals, azoles for yeast, metronidazole for trich, treat partner 2.
Pelvic inflammatory disease, PID.
Ascending infection of upper genital tract, uterus, tubes, ovaries, often from STIs like chlamydia, gonorrhea, presents with lower abdominal pain, fever, cervical motion tenderness, chandelier sign, abnormal discharge, can be subtle. Minimum criteria for empiric treatment exist, can lead to tubo-ovarian abscess, TOA. Treatment, broad-spectrum antibiotics, outpatient or inpatient regimens. Treat partners, complications, chronic pain, infertility, tubal damage, ectopic pregnancy, Fitzhugh-Curtis syndrome, perihepatitis,
Ovarian torsion.
twisting of ovary on its vascular pedicle, cutting off blood flow, ischemia necrosis. Acute onset, severe colicky pelvic pain, often nausea, vomiting. Risk factors, ovarian cismus, pregnancy. Diagnosis, clinical suspicion plus pelvic US with Doppler, looking for absent abnormal blood flow. Treatment, surgical emergency, laparoscopy to detorsive viable or remove ovary for oophorectomy if necrotic. Time is critical.
Pediatric vaginal discharge.
Common causes in kids: foreign body, toilet paper often, infectious vulvovaginitis, group A strep, common bacterial cause, candida less common unless recent antibiotics, consider STI subuse if found, poor hygiene, irritation. Treatment depends on cause. Remove foreign body, antibiotics for infection, hygiene education.
Toxic shock syndrome.
TSS. Systemic reaction to toxins produced by Staph aureus, TSST1, or strep pyogenes, often associated with retained tampons, but also non-menstrual wounds, burns. Abrupt onset high fever, vomiting, diarrhea. Diffuse sunburn-like rash often includes palm soles. Hypertension, multi-organ involvement. Later desquamation peeling of palm soles. Diagnosis is clinical based on criteria. Treatment, aggressive IV fluids, remove foreign body, drain infection source. Broad spectrum IV antibiotics, including one that reduces toxin production, like clindamycin, plus anti-staph coverage, like vancomycin initially. High mortality if not treated promptly.
Okay, switching to benign breast disorders.
Very common. Can be non-proliferative, generally no increased cancer risk. Include simple cysts, fluid-filled, common, fluctuate with cycle. Fibrocystic changes, lumpy, bumpy tissue, often cyclic pink tenderness. Fat necrosis, often after trauma, can mimic cancer on imaging. Or proliferative without atypia, small increased cancer risk. Includes usual ductal hyperplasia, sclerostin adenosis, intraductal papillomas, most common cause of bloody nipple discharge, usually benign but need excision. Or proliferative with atypia, atypical hyperplasia, ADH, ALH, moderately increased cancer risk. Looks like low-grade DCIS, LCIS, but doesn't fill the duct label, usually found incidentally on biopsy. Requires excision and risk reduction strategies. Surveillance, possibly meds like tamoxifen.
Diagnosing breast lumps.
Approach depends on age. Generally 30O ultrasound first, 30O mammogram first, often followed by ultrasound. Suspicious solid lesions need biopsy. A core needle biopsy is standard. Cysts can be aspirated, FNA, if fluid is clear and mass resolves, usually benign. Bloody fluid or residual mass needs biopsy.
Delodes tumor.
Less common than fibroadenoma, but grows larger faster, looks leaf-like on pathology. Can be benign, borderline, or malignant. Needs wide excision because of recurrence risk.
Okay, let's talk breast cancer.
Most common cancer in women, excluding skin. Second leading cause of cancer death. Risk factors: female sex, increasing age, personal family history, BRCA1, BRCA2 mutations, radiation exposure, certain benign breast conditions like atypical hyperplasia, increased lifetime estrogen exposure, early menarche, late menopause, nulliparity, late first pregnancy, obesity, alcohol use.
How does it present?
Early stage, often asymptomatic, found on screening mammogram or as a new, painless, firm, irregularly fixed lump. Later signs: skin changes, dimpling, redness, peau d'orange like orange peel, nipple retraction or discharge, especially bloody, palpable axillary nodes. Paget's disease of the nipple, scaling, eczema-like rash associated with underlying DCIS or invasive cancer, metastatic disease, bone pain, cough dyspnea, jaundice, neurological symptoms.
Screening guidelines.
Vary slightly between organizations, generally annual mammography starting at age 40 or 45, continuing as long as woman is in good health. Clinical breast exams recommended. High-risk women, BRCA carriers, strong family history, may start earlier and add MRI screening.
Diagnosis.
Based on imaging, mammogram, ultrasound, MRI, and confirmed by biopsy. Core needle, usually. Biopsy provides tissue for diagnosis and receptor testing. Estrogen receptor ER, progesterone receptor PR, HER2. Staging involves assessing tumor size, node involvement, metastases, TNM staging. Multimodal, depends on stage, receptor status. Local treatment, surgery, lumpectomy plus radiation or mastectomy, and axillary node assessment. Sentinel node biopsy usually. Systemic treatment: endocrine therapy, tamoxifen for pre-postmenopausal ER+, aromatase inhibitors for postmenopausal ER+. For hormone-sensitive tumors, HR2 targeted therapy, trastuzumab Herceptin, for HR2 plaque tumors, risk of cardiotoxicity. Chemotherapy based on risk stage subtype. Highly dependent on stage at diagnosis. Early stage has excellent prognosis, 90% 5AR survival. Prognosis decreases with increasing stage, positive nodes, certain subtypes like triple negative. Metastatic, stage 5, is generally incurable but treatable, 5AR survival, 25%.
Okay. Back to benign GYN, uterine leiomyomas, fibroids.
Extremely common, benign, smooth muscle tumors of the uterus. Hormone sensitive, grow with estrogen, shrink after menopause. More common in Black women, often asymptomatic. Symptoms depend on size, location. Heavy prolonged bleeding can cause anemia, pelvic pressure pain, urinary frequency, constipation, infertility. Uterus often feels enlarged, irregular, firm on exam. Diagnosis usually by pelvic exam and ultrasound. Treatment observation if asymptomatic. Medical options for symptoms, OCP's progestins for bleeding, GnRH analogs to shrink temporarily, pre-op, NSAIDs for pain.
Yeah.
Surgical myomectomy removes fibroids, preserves uterus fertility, or hysterectomy definitive. Uterine artery embolization is another option.
Gynecologic cancers, endometrial.
Most common GYN cancer in U.S., usually adenocarcinoma. Type I, most common, 75%, is estrogen-related, arises from atypical hyperplasia, better prognosis. Type 2, serous clear cell, is not estrogen-related, more aggressive. Risk factors: unopposed estrogen, obesity, PCOS, tamoxifen, estrogen-only HRT, age, diabetes, Lynch syndrome. OCPs are protective, main symptom. Abnormal bleeding, especially postmenopausal bleeding. Diagnosis: endometrial biopsy. Treatment: usually hysterectomy with bilateral salpingo-oophorectomy, BSO, and staging, lymph node assessment, radiation chemo for advanced disease.
Ovarian cysts, again, what about cancer risk?
Most cysts in premenopausal women are benign functional cysts, follicular corpus luteum. Postmenopause, new cysts are more concerning. Features suggesting malignancy on ultrasound. Large size, solid components, thick septations as sites. CA-125 tumor marker can be helpful, especially postmenopause, but not specific. Persistent or suspicious cysts require surgical evaluation.
Cervical cancer.
Mostly caused by persistent high-risk HPV infection. Types 16 and 18 cause most. Risk factors: HPV, smoking, immunosuppression, early onset sexual activity, multiple partners. Prevention: HPV vaccination. Gardasil 9 covers 9 types. Screening: Pap smears plus HPV testing detects precancerous changes. CIN, cervical intraepithelial neoplasia, which are treatable. Screening starts at 21. Frequency depends on age and prior results. CG, PAP3, or co-testing 5-Coir for ages 30-65. Symptoms of invasive cancer: postcoital bleeding, intermenstrual bleeding, foul discharge, pelvic pain, late. Diagnosis via colposcopy with biopsy. Treatment depends on stage. Leap cone biopsy for CIN, surgery, hysterectomy, plus radiation and chemo for invasive cancer.
Vulvar and vaginal cancer.
Much rarer. Vulvar, often squamous cell, presents with itching, cane, lump, bleeding, associated with HPV or chronic skin conditions, lichen sclerosis. Vaginal, often squamous, presents with bleeding, discharge, mass. Clear cell adenocarcinoma linked to DS exposure in utero. Diagnosis by biopsy. Treatment usually surgery plus Lysine radiation.
Ovarian cancer, high mortality.
Yes, highest mortality of GYN cancers because often diagnosed late, stage 3. Symptoms are vague: bloating, pelvic abdominal pain, early satiety, urinary changes. Risk factors: age, family history, BRCA12 mutations confer high risk, Lynch syndrome, nulliparity, infertility, endometriosis. OCP use is protective, no effective screening for average risk women. Diagnosis often suspected based on pelvic exam, ultrasound, CA-125, confirmed surgically. Treatment: surgery, debulking, staging, hysterectomy, BSO, omentectomy, node sampling, followed by chemotherapy, usually platinum-based, for most epithelial cancers. Different subtypes exist: epithelial, germ cell, sex cord stromal, with different markers and treatments. Germ cell tumors often occur in younger women, may produce AFP or HCG. Granulosa cell tumors produce estrogen. Any ovarian mass in premenoptical or postmenopausal woman is suspicious.
Urogynecology, pelvic floor issues.
Deals with pelvic organ prolapse, uterus, bladder cystocele, rectum rectocele falling down, and urinary fecal incontinence. Prolapse, risk factors: childbirth, age, obesity, chronic straining. Symptoms: pelvic pressure, bulge, urinary bowel dysfunction. Treatment: Kegels, pessary, support devices. Surgery: urinary incontinence, stress, urge, mixed is also common, managed with lifestyle changes. PT, meds, surgery.
Sexual disorders.
Important aspect of GYN health. Includes issues with desire, arousal, orgasm, pain. Genitopelvic pain penetration disorder includes vaginismus, involuntary pelvic floor muscle spasm preventing penetration. Vulvodynia, chronic vulvar pain. Female sexual interest arousal disorder. Causes can be multifactorial: physical, psychological, relationship. Treatment is often multidisciplinary: therapy, PT, meds.
Wow, okay. That was an incredibly thorough deep dive. We went from the very start of pregnancy through labor, postpartum, and then a huge range of gynecologic health topics from puberty to menopause and beyond.
It really covers the whole lifespan, doesn't it? And what strikes me is how interconnected everything is: the hormones, the anatomy, the physiological changes. It's complex, but understanding the basics makes it less daunting.
Absolutely. There were definitely some aha moments.
Ah,
Me really grasping the hormonal cascade in lactation and how it connects to suppressing ovulation was great. And the Veal-Seachock mnemonic for fetal heart tones. Also, the PALM-COEIN framework for AUB that really helps organize thinking.
Exactly. And hopefully for you, our learner, this deep dive has provided that shortcut to understanding, cutting through some of the complexity and offering clarity on these essential OBGYN concepts.
We really hope this has given you a solid foundation. Maybe it sparked some new questions or areas you want to explore further. If so, let us know. Think of this as a springboard for more specific learning when you need it.
And maybe a final thought to leave you with, consider the ongoing progress in women's health. Research continues to refine personalized care predicting preeclampsia risk, tailoring cancer treatments based on genetics, improving fertility options. It's exciting to think about what future advancements will mean for improving the health and well-being of women across their entire lives. It's a field that's always moving forward.